Good evening, esteemed faculties and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar, organized by Fetal Medicine Committee and Aurangabad OBGY Society. So let me introduce the MOC of today's webinar, Dr. Sunita Kedkar. Ma'am is the consultant and director of Kedkar Maternity Hospital since 14 years, and ma'am has worked as a registrar at Wadia Maternity Hospital and ex-consultant at MIT Multi-Specialty Hospital. And her field of interest is obstetrics, sonography, infertility, and menopausal health. I welcome you, ma'am, and I hand over the session to you.
Thank you for kind introduction. I would like to welcome all on behalf of Aurangabad OBGY Society and Fetal Medicine Committee AMOX. Firstly, I'd like to invite Chairperson of Fetal Medicine Committee, Dr. Sujit Konkar, sir. Sir has done MBBS and MD from GMC Aurangabad. He has done his basic USG training at Dr. Bimal Sahani, sir, Sonoscan Center, Aurangabad. He is FMF certified sonologist for 11 to 13 week scan, preeclampsia screening, Doppler ultrasound, and fetal abnormalities. He is Secretary of Society of Fetal Medicine, SFM, Marathwada chapter. His Sri Hospital is Foxy approved USG training center. His keen interest is in advanced fetal ultrasound. And currently he is chairperson of Fetal Medicine Committee, AMOX. Welcome, sir. I'll request you to say a few words.
Thank you for kind introduction. Good evening, dear friends, colleagues, and seniors. Warm welcome from Fetal Medicine Committee, AMOX. At the outset, I would like to welcome first our President, AMOX Pardesi, sir, for this webinar. Sir, your words of wisdom are very important for us. Dr. Patel ma'am has not joined yet. So welcome our guest of honor today, respected Sitapal madam and respected Dr. Chinmayratha ma'am. We are waiting eagerly for your words of wisdom and blessings, ma'am. And then I would like to welcome here our chairpersons today, Indrani Roy ma'am and Dr. Gogoi. Most importantly, I would like to welcome the most important persons today, speakers, Dr. Chaitanya Datta sir and Dr. Manoj Toshniwal. He is yet to join. And most importantly, I would like to welcome all delegates who have logged in for this webinar. And regarding this webinar, there are two topics. One topic, basics things on genetics, which will be covered by Dr. Datta sir, which is very, very important in our day-to-day obstetric practice. And second talk will be covered by Dr. Manoj Toshniwal. He is going to speak on hemoglobinopathies in pregnancy. So over to you, Dr. Sunita, for next proceedings. Thank you.
Thank you, sir. I'd like to invite guest of honor, Dr. Sita Ramurthy Pai. Madam is consultant fetal medicine and obstetrician at Apollo Multi-Specialty Hospital, Kolkata. Madam is clinical secretary of Bengal Obstetrics and Gynec Society in year 2022 to 23. Chairperson elect of Genetics and Fetal Medicine Committee, Foxy, 2023. Fellow of, yes, ma'am.
Thank you, Sunita. That's okay. I think this is an old one, but thank you once again for the invitation. But I'm currently the chairperson of the Genetics and Fetal Medicine Committee. But nevertheless, thank you, Sujit, for this wonderful webinar. And it's always a pleasure and pride to be part of your AMOGS activities. And you do such wonderful AMOGS, be it in every aspect of medicine, be it fetal medicine. And I've attended quite a few of these sessions. They're very, very good and very a lot of learning in that. And I think today's topic has been my greetings to Pardesi Singh sir, who's always been, from our good old science days, we've been inspired by him. And so first of all, it's a very, very important topic you've selected today, and I congratulate you for that, because genetics has taken our world by storm, and be it every aspect of obstetrics and gynecology. And in fetal medicine, nevertheless, goes without saying that every aspect that we see is related to genetics. And hemoglobinopathies, of course, is also a very important aspect we face in our day-to-day life. There are so many confusions despite that regarding how to interpret, how to diagnose, and what is the way forward, and whether to do invasive or not. So, and I think you've selected the right topics and the right speakers, especially Dr. Chaitanya Datar and Dr. Toshniwal, who are authorities in their field. So it will be a wonderful academic feast, I'm sure. So thank you, and wishing you all the best for this webinar, and wishing you all the best for your chairperson of the imaging committee as well.
Thank you. Thank you, ma'am.
Best wishes for that. Thank you once again for this opportunity.
Thank you, ma'am, for your blessings and words of wisdom. Now, I'd like to invite Dr. Chinmay Radha, ma'am. Madam is director at Resolution Fetal Medicine Center, Hyderabad. She is leading consultant.
It's okay.
Fetal
It's
medicine
okay,
at the
Dr.
hospitals.
Sunita. Actually, I would like to take that extra minute to just speak to you. First of all, good evening, Pardesi sir. And it's always a pleasure to be part of the Aurangabad Society activities, because we have really good friends there. And Dr. Sujit particularly has a lot of passion in whatever he does. And when he does it, he always adds an extra dimension. So as Fetal Medicine and Genetics Committee chairperson in AMOGS, I'm sure he's doing so many activities. At least I have been part of so many of his activities till now, that I'm looking forward to his bigger roles in the organizations as he is looking forward to. So like Dr. Sita said, it is indeed a very important aspect to address genetics, clinical genetics in the current practice, because genetics is something we are realizing how many of our problems are actually originating from issues with the genes, and how we can use these genetic tests optimally in clinical practice is still not very well understood. Many tests are done which are not indicated, and many tests are done which are not at the right time. So an average obstetrician is getting carried away by the way industry is floating some tests. So, there's a lot of whole exomes advised for no reason, and then people realize that that was not the right test to do. So I think that the session on genetics will be very, very enlightening. And the other issue is hemoglobinopathies. Again, something which we've been brushing under the carpet and not realizing that we do have a significant burden of hemoglobinopathies, and something which can be actually prevented in some way, because a simple test like an HPLC will take us a long way in, avoiding a very bad, as a near miss kind of situation in pregnancy. So I'm looking forward to that talk also. And it's really a pleasure to be here amongst friends again, Dr. Indrani, Dr. Gogoi. Very nice to interact with you. And I hope that we will have a very, very nice evening. Thank you so much. Congratulations, Dr. Sujit.
Thank you, ma'am. I'll now invite Dr. Rajendra Singh Pardesi, sir, President AMOGS, to give his blessings. Sir is leading consultant at Aurangabad, private practitioner, senior private practitioner.
Okay, Sumita. Good evening, everybody. Respected Chief Guest, Dr. Madhuri Patel, Guest of Honor, Dr. Sita Pal. We still remember the warm hospitality by Sita Pal and team AISUG Kolkata. Dr. Chinmay Ratha, now AISUG 2024 is coming. So it's a challenge for you, right now. Dr. Sujata Devi, our President, Dr. Aparna Rao and Shraddha Paritkar and friends. First, I wish to congratulate Dr. Sujit Konkar and Dr. Sunita Khedkar for organizing this webinar on hemoglobinopathies and genetics. So he told me, sir, this is the CME on genetics, because we have masters, Dr. Chaitanya Datar and Manoj Toshniwal. And as Dr. Chinmay that told, see, there are too many problems in our area, in border areas, hemoglobinopathy, sickle cell, and all those patients are quite a lot. Patients are there. Even genetic problems also, their prevalence is there in our Marathwada. So he told me, sir, should I float all? So, okay, you can see, even if AMOGS is there, but you can involve all, because as Dr. Konkar is chairperson of our Fetal Medicine Committee, and he is having FOPSI recognized training center in USG, and he's interested in fetal medicines. So she invited Dr. Indrani Rai, Dr. Jitendra Gogoi as a chairperson. So with these all expertise, I think this will going to be a great webinar. I wish every success to Dr. Sujit Konkar for his future endeavor in Fuxi as he wanted to contest for chairperson of Imaging Science Committee. Wishing every success to this webinar. I don't want to be in between you and nice, excellent scientific content by Dr. Chaitanya Datar and Manoj Toshnewal. Thank you. Thank you so much for inviting me.
Thank you, sir. Your words of wisdom will always inspire us. Now, I'd like to welcome President Aurangabad Society, Dr. Aparna Rao ma'am, and Secretary Dr. Shraddha Paritkar.
They have not joined it, I think.
Yes, they are yet to join. So we can move ahead with our academic session.
Sure.
Our first chairperson, I would like to invite Dr. Indrani Roy ma'am. Ma'am is senior consultant and HOD obstetrics and gynecology at Nazareth Hospital, Shillong. She is President SOGS 2017 to 19, organizing chairperson of EZYF 2019, organizing chairperson of National Yuva IAG 2022, member of Breast Committee FOXY 2022 to 24, and she is DNB teacher. Welcome, ma'am.
Thank you so
I'll
much.
request Indrani ma'am to kindly invite our first speaker, Dr. Chaitanya Datar, sir.
Good evening, everyone. At the outset, I would like to thank Pardesi sir and, of course, Dr. Sujit for giving me this opportunity today for this wonderful webinar. I think this is a very important topic, and I think we'll be all benefiting excellently today with this academic session. So I would like to welcome our speaker today, Dr. Chaitanya A. Datar. He is a consultant clinical and metabolic geneticist. He's the director of Sujan Clinics, Pune, Mumbai, Nashik, and Solapur. He has more than 30 publications in national and international journals, and he's in charge of the fetal program in genetics and metabolics at Bharti Hospital. He's also the Joint Secretary, Indian Society for Inborn Errors of Metabolism, and his special interests are dysmorphology and phenotyping, fetal autopsy, prenatal diagnosis, neurogenetics, analysis of next generation sequencing data. So Dr. Chaitanya, I would like to welcome you for today's talk. The platform is yours.
Thank you so much, Dr. Indrani, Dr. Rajendra Singh Pardesi, sir, Dr. Sita Pal madam, Dr. Ratha madam, and Dr. Konkar. Thank you so much for this opportunity. So I'll, without much ado, a very good evening to all the delegates who have joined. So I'll share my screen. I hope you can hear me well.
Yeah.
Thank you. So the topic that has been allotted or given to me today is decoding genetics in obstetric practice. So to understand essential tests and timelines. So as Dr. Chinmay ma'am just mentioned that a lot of tests have come up, but we need to do the correct test at the correct time to give an optimal result or a correct result to the patient. So in this regard, we must understand that which tests are available and when to use them and how correctly to interpret them. So my first question always is, do these 46 chromosomes constitute our genetics? So the answer is yes, and the answer is no as well. The reason being, essentially when you're looking at a chromosome, so assume that it's a long thread which is coiled and supercoiled to form a compact structure. So if vice versa, you open a chromosome, it is a long thread of DNA. So you have disorders at various levels. So certain chromosomal disorders like Down syndrome, Turner syndrome can be diagnosed based on a karyotype. While if you're looking at certain chromosomal segments or certain segments of DNA, that is what is diagnosed by a microarray or a chromosomal or a CGH microarray. While if you're going to the rung of the ladder and looking at the basis, that is A, T, G, C, that is when we are doing an exome sequencing or a Sanger sequencing. So I liken this to a bookshelf. So wherein we have 46 books on a bookshelf. So when I'm doing a karyotype, I'm looking at every book from outside and keeping it back. When I'm doing a microarray, I'm looking at the chapter level. While when I'm doing a Sanger sequencing or a next-gen sequencing, in Sanger, I'm opening a single page, a single line at a time. While when I'm doing a next-gen sequencing, which includes exomes and genomes, then I'm opening multiple pages to read them at a time to find out an abnormality as small as a single letter being changed. So when we're going from a gross book level to a letter level, that's the variable resolution that we're looking at. So all tests are not equal, and therefore we need to use these tests really judiciously. Now, we had this karyotype in fish as early as 1983 and 2000. And now we are all talking about exomes, arrays, and the NIPT and the newer things on the block, that is the NICS or your PGTs, etc. So, do these newer tests do they replace the old ones, or are they complementary is what we must understand. And in the obstetric setting, I'll take you through various case-based scenarios pertaining to infertility, recurrent pregnancy losses, product of conception studies, antenatal setting wherein we'll be evaluating for abnormal markers, soft markers, or various anomalies, and how do we really approach these cases. Now, when we're talking about recurrent pregnancy loss, it's one of the common problems that obstetricians face. So essentially, when we're talking about an RPL, it's 2, 3 or more consecutive losses of proven pregnancies. So these are not biochemical pregnancies, it's proven pregnancies with post-implantation failure of conception. That is divided into two. When the loss happens before 24 weeks or 500 grams, before the fetus is really capable of an extrauterine survival, that is when we are calling a miscarriage. But if it happens beyond 24 weeks, that's usually called an intrauterine death or a recurrent fetal loss. Well, what is a recurrent implantation failure? So when you're talking about a recurrent implantation failure, it is 3 consecutive failed in vitro fertilization attempts with at least 4 good quality embryos. And we have to consider the maternal age and the embryo stage, etc., when we are talking about a recurrent implantation failure. I usually like to show this particular slide wherein what we are actually getting as live births, it's only a tip of the iceberg. So it's only about 25% of all conceptions are going to really lead to a live pregnancy, while most of them, almost 75% of them, either they're going to have a miscarriage or very, very early pregnancy loss because of even an implantation failure. So as the pregnancy advances, so you're at conception, when you're getting a visible GSAC, when you're getting a fetal heart sound and a miscarriage thereafter, we have the various aspects here. So if it is at conception, so it's infertility, when you're getting very, very poor quality embryos on IVF, the chromosomal cause, the red part is a chromosomal factor, is more prevalent. So we need to look at chromosomes essentially when there's infertility and you're getting poor quality embryos on IVF. As compared to that, the other factors are less likely to be responsible. Once you've seen the GSAC, but no heart sounds, that is a very early loss at around 5-6 weeks. About 50% of these cases could have a genetic chromosomal or single gene etiology, while the rest could be endometrial, hormonal, infectious, or metabolic causes. Now, once the fetus goes to a stage wherein the heart sounds have started, that time the chromosomal element comes down further. So only about 20-25% of these cases could be chromosomal, but a large chunk could be APLA, that is the antiphospholipid antibody syndrome, either thrombophilias or some metabolic causes like hyperhomocysteinemias. When we're talking about things beyond 12 weeks, that is IUDs beyond 12 weeks, essentially the other causes like APLA have to be reviewed, but at the same time, we have to look at single gene causes, not chromosomal causes. So essentially, when we're dealing with IUDs, we may have to look at, a gene-based test over and above a chromosomal study. Now, when we're talking about recurrent infertility or recurrent implantation failures, it's always should be a couple testing. So essentially, both the gametes are to be used. It should be a couple testing, and karyotype is a test of choice. Now, what do you expect on this? Sometimes you're going to get some extra missing chromosomes, rarely, and in many cases, you're going to get structural rearrangements. Microarray is generally not useful in this setting. So we'll just see some examples like chromosomal numerical abnormalities, like individuals with Klinefelter or Turner syndrome may be identified on a karyotype. But more commonly, what we find is something called balanced translocations, wherein if it is a male with oligospermia or azoospermia, females with a very low AMH or ovarian reserve, if you are getting IVF with very, very poor embryo quality or recurrent implantation failures or pregnancy losses, there you are more likely to find a balanced translocation. So here in this picture, you are seeing that there's a translocation between chromosomes 3 and 22. So there's a 322 translocation. So you need a very good karyotype to really identify balanced translocation. So that's why I always emphasize the quality of karyotype is crucial. We just don't want to see the 46 number. It is the quality that is very important, because we nowadays get such subtle translocations, which some of them have required some advanced techniques to really diagnose. Now, sometimes you get in infertility cases, a male. In this case, we have had a male with a marker chromosome. So there was a history of infertility along with 2 miscarriages and 2 IVF failures. And when a karyotype was done, there was an extra chromosome which was lying, which was further characterized to be chromosome 15 on this very beautiful assay, which is called as a spectral karyotype, wherein you're giving a color to each chromosome. This is nowadays coming handy for various subtle balance translocations as well. Now, when you're dealing with recurrent pregnancy losses, again, remember it should be a couple test. It should not be only in the lady. It has to be done as a couple. Karyotype is a test of choice. What we expect here more commonly is a balanced chromosomal rearrangements. Here you will rarely expect a Turner syndrome or such cases, but it will be more of balanced chromosomal rearrangements, and microarray should not be considered unless in exceptional cases. So when you're dealing with a recurrent pregnancy loss and you're testing the couple, it should be a karyotype is the test of choice. Now see this case example wherein there's a 6 years period of infertility with 1 miscarriage, 6 IUI attempts, 3 IVF attempts, and 2 embryos were transferred and they miscarried. And ultimately, when they did a karyotype, it showed a translocation between chromosomes 1 and 2. So you can see a very subtle translocation between chromosomes 1 and 2. So coupled karyotype should be done in all cases before an ART is attempted, irrespective of previous POC results or previous obstetric history. So we must remember karyotype is a test of choice with recurrent pregnancy losses. This is why I highlight we must consider karyotype in all cases. This couple had a healthy female. The second and third pregnancy ended in a miscarriage. And in the fourth pregnancy, there was an 11q microdeletion. Essentially, that was identified on the microarray. And when the karyotype was done, the husband was a carrier of a very complex translocation between chromosomes 5, 13 and between chromosomes 12 and 11. So here there was a double translocation, and hence the outcomes were quite guarded in view of this particular complex karyotype that we have. So overall, there is a very less chance, about less than 10% chance of a successful conception by using their own gametes. Now, there were multiple IVF failures in this particular couple, and a couple microarray was noted to be normal. So, do we only rely on microarray for IVF failures or recurrent implantation failures or pregnancy losses? No. What you see here, there's a translocation between chromosomes 8 and 13. We must remember when we're doing a microarray, we are dealing with copy number variation. So we're trying to find out if there's some extra or missing genetic matter in that individual. Now, what we expect in a balanced translocation, there's no gain or loss of matter. It is just that they have translocated, they have exchanged their position. So as a result of which, whenever we do a microarray, it will turn out to be normal. But a karyotype has given the answer, and this couple, it has overall, because of the translocation, has less than 15% chance of a successful conception with their own gametes. Otherwise, they would either land up with IVF failures, miscarriages, or sometimes fetuses with anomalies. So remember, karyotype is a test of choice in couples. Now we go to the second aspect, which is the products of conception. We must remember products of conception is a unique sample because we're doing a direct genetic study on the fetus to try and understand the etiology of the recurrent pregnancy loss. So pregnancies will usually discontinue because of imbalances. So a balanced rearrangements here are not important. So here we will utilize microarray because of a few reasons which I'll discuss in some time. But microarray is a test of choice on POC samples. Fish and karyotype can be done, but the information is obtained is very limited because when you're doing a fish, we are getting information only about 5 chromosomes, that is 13, 18, 21, and 6 chromosomes. While when you're doing a karyotype, which most of the time may fail because it's a non-viable sample. So in these cases, again, the information remains very limited only up to the chromosome. But when you're doing a microarray, we get a much detailed information. Now, in this particular case, there have been 2 early miscarriages, and there was a trisomy 16 on a product of conception sample. Both were natural pregnancies. So how do we counsel these couples when they've had a trisomy 16? Obviously, we'll do a karyotype or a basic chromosomal study in both of them. And if both their chromosomes are normal, the recurrence risk will be less than 1%. The reason being, when you're finding an extra chromosome, it is an aneuploidy. So essentially what we find here is both the parents have 46 chromosomes, but when they're contributing the chromosomes to their offspring, both of them are going to contribute 23. That is 23 from the sperm, 23 from the egg will give rise to a cell with 46. But occasionally, there's this abnormality in meiotic division wherein one partner contributes 24 instead of 23. And when 24 and 23 unite, it gives rise to a cell with 47. So that one extra chromosome is usually an accidental event. So we say that the risk of recurrence in such couples is going to be less than 1%, and they can absolutely plan a natural conception. But in this case, what we found on a microarray was a complete trisomy 14. That is 14th chromosome, instead of 2 copies, there were 3 copies. Now, what we find here is when we do a couple karyotype, we find that the mother is normal, but the father is a carrier of a Robertsonian translocation between chromosomes 13 and 14. Now, here your things are going to change, because since one of the parent has a balanced translocation, the risks are going to be higher. With the risks of successful pregnancy chances is only about 10 to 15% with their own gametes. Other pregnancies will either end up as miscarriages, infertility, or sometimes fetuses with anomalies. And rarely, because of trisomy, since chromosome 13 is involved, there could be babies who are born with physical or intellectual impairment. So here what we see, the cartoon on the left is a little complex, but we almost have about 16 combinations, out of which only the 2 top combinations are going to actually lead to a normal conception. The rest, all of them are going to have either extra or missing genetic matter, which will lead to problems. Now, rarely on a microarray, see, when you're doing a microarray, you're not looking at the book, not only looking at the book from outside, but also going to the chapter level. So here in this case, at 10, 11 weeks of pregnancy, the heartbeat had started and it stopped. When the product of conception was tested, it showed a 1.8 megabase deletion on chromosome 15. So it's something called 15q microdeletion. Now, obviously, in such cases, when you're getting a microdeletion, we should always consider a microarray in addition to the karyotype. Now, here what we find is a microarray in the parents was normal, so we could assure them that this was a freak accidental event wherein that small chromosomal piece just fell off. And obviously, the risk of recurrence is going to be, it's a de novo event, so the risk of recurrence is going to be less than 1% is what we could tell them. Now, therefore, again, coming back to the question, which test should be considered on a POC, a FISH or a karyotype? Both could be considered. We must remember that karyotype, there are difficulties in culture. There's a risk of bacterial contamination, about 70 to 80% risk of a culture failure rate, and also maternal cell contamination. While FISH, we are only evaluating for 5 chromosomes. So very, very limited information is what can be obtained from here. Then why microarray is the test of choice? Because microarray is looking a little deeper. So it gives about 15-20% more information than a karyotype. It can pick up all imbalanced chromosomal rearrangement. So anything at the chromosomal level which can cause a miscarriage can ideally be picked up by a karyotype if you're using the correct resolution. So ideally, you can use a low resolution microarray. It can be performed on stored DNA. Sometimes what happens, the patients may not have the funds to do the test immediately. So you can always store the DNA, and on that stored DNA, we can always consider a test. It does not require culture, so the risk of bacterial contamination is less. Only balanced translocation are missed, which again are less likely to be causative of a miscarriage. So there have been multiple studies which are now highlighting the importance of microarray in POC samples. Now we'll go to switch gears and we'll go to pregnancy. And first we'll discuss about screening tests, which should be offered to all patients, offered to all. Okay, so it's not a compulsion, but it should always be offered to all the patients. So wherein HPLC for thalassemia, we'll be discussing that in the next talk. The various biochemical markers to be done in conjunction with the MT scan and the non-invasive prenatal screening, or NIPS or NIPT. You can always provide that option as well. So we'll be just discussing some cases in that regard. Screening for beta thalassemia and sickle cell disease is very, very crucial, because there's a very, very high carrier rate of thalassemia and sickle in certain belts, not only of Maharashtra, but also certain belts of India. And hence, an HPLC, a very, very simple, inexpensive test for HPLC, must be performed in all ladies who come for an ANC visit. So usually the protocol can be, you screen the lady by an HPLC, and you find if she's normal, no need to test the husband. If she is showing an HbA2 concentration more than 3.5%, obviously we should test the husband by HPLC. And if both of them are showing an abnormal result or a high HbA2 level, then we should go for a genetic study. Genetic study for thalassemia is not expensive, and just by looking at about 5-6 common mutations account for 90% mutations in our population. And this gene is a very, very small gene, so it can be sequenced very, very rapidly, and we get a good result in a very short time. one thing that we must remember that this test, this is not detected by NIPT, because we have seen, prescriptions NIPT for thalassemia. You cannot detect NIPT as of thalassemia on NIPT as of today. It should be a mutation studies and by an invasive testing. Then screening for Down syndrome. Now, many a times the question comes up, why should young ladies be screened for Down syndrome? The risk is not going to be high. But what we see today is majority of Down syndrome babies are born to ladies who are less than 30 years of age. So Down syndrome screening should ideally be universal. And why we should consider, because parents are normal, as I just discussed this earlier, there's a meiotic abnormality, and as a result of which one of the parents contributes an extra chromosome accidentally. So these are all accidental issues. They're not age related, though they can happen at any age. The risk goes on increasing as the age advances. So it should be considered the Down syndrome screening by an NT scan or a knuckle translucency scan at 12-13 weeks. And you always incorporate the NT value along with a double marker test to get a combined risk result. So what are the various tests available, prenatal screening options? If you're using only NT, a good NT can give about a detection rate of about 70%. If you're using a good double marker screening along with an NT, then both are done with standardized places, then approximately about 85 to 90% detection rate is possible. Triple screen, remember, is obsolete. Triple screen, the detection rate is only about 65-70%. It's not a very optimal test. In case you've missed the first trimester, go for a quadruple marker test, which has a little better accuracy because of inhibin A, about 75%. But ideally, we should try to target the NT scan along with a double marker and should be offered to all ladies to avoid medico-legal consequences. Then what does prenatal screening detect? So it's essentially one thing when during counseling that we must explain to patients is that prenatal screening is a test mainly to screen for Down syndrome, but it will also give risks for trisomy 18, 13, triploides, Turner syndrome. If you're doing an AFP, it will give a risk for open neural tube defect. And as we are now learning that there are various markers for adverse pregnancy outcomes like preeclampsia or SGA babies, etc. We can draw conclusions based on some of these screening tests. Now, one very, very important aspect which the obstetrician should ideally look at, don't just look at there's a high risk or low risk here. Look at the MOM values or mom values. Moms are multiples of median. So what does that mean? So suppose we take an example at 13 weeks, the beta HG value should be about 33.45 in an average population. Now, if the lady has a value of 15, her value is half, so it will be 0.5 mom. If at that point her value is about 63, the value is doubled, so that's 2 mom. So essentially, what we are dealing with is how many times that the biochemical element is increased or reduced as compared to what it should be at that particular gestation. So always look at the mom values, because essentially a high beta HCG and low PAPA would indicate a trend towards Down syndrome. So now we see a 23-year-old lady who's a primey with an NT scan, NT of 1.4 mm at 12 weeks. And what we find here is all the mom values, if you look at them, NT is 0.92, BPAPA is 1.31, beta HCG is 0.87, all are very, very close to 1. So that indicates that this is a fairly good result, and therefore the final risk is about 1 in 28,000. So what does that mean? That essentially you've looked at Down syndrome or ruled out Down syndrome with 85 to 90% accuracy. So it's not a 100% detection rate, but 85 to 90% you're sure that this baby will not have Down syndrome. But now look at this. This is a 35-year-old lady with 3 first trimester miscarriages and no genetic workup was done. NT was 1.2 at 12.3 weeks. And you can see the mom value, see the trend. Beta HCG is elevated, it's almost close to 3. While PAPA is only 0.25, which is much lesser than 1. And the trend is indicating that it could be a Down syndrome-like pregnancy. But always consider, we must remember this is a screening test. The risk is 1 in 90. So though it's an increased risk, it doesn't indicate always that the baby is abnormal. So always it is indicated to consider invasive testing for such cases. So essentially here you're finding the risk of 1 in 90. So when you do an invasive test, so what test would you opt for really? Whether you go for an NIPT or invasive testing is nowadays the question. So usually as a gross, though it has to be individualized as per cases, NIPT can be used for intermediate risk patients or a risk between 1 in 100 to 1 in 250. Intermediate risk is from 1 in 250 to 1 in 1000 is what is intermediate risk. and 1 in 100 to 1 in 250 is the increased risk. It's a low age risk. So it's a young mother, less than 35 years. There's no bad obstetric history. The NT value is normal without any other soft marker, and the marker trend is not too adverse. Then in these cases, you can opt for an NIPT. But in case the risk is more than 1 in 100, it's an advanced age, there has been a bad obstetric history, it has been an ART pregnancy, an IVF conception, or all cases with high NT or anomalies or major soft markers, always opt for an invasive testing. So these are rough guidelines, though it has to be really individualized for cases. But in this case, obviously, we had a higher maternal age, there was a bad obstetric history, there was an increased risk, which was more than 1 in 100, and a significantly adverse marker trend for which we considered an invasive testing, and the fetus turned out to be a Down syndrome case. Now, in this case, again, NT of 5 millimeters, there was scalp edema, and you can see the marker trend is abnormal, the NT is very, very high. Obviously, it's showing an increased risk for all the three conditions. Now, in these cases, obviously, we have to consider an invasive testing. NIPT is definitely not the test of choice. But what we must know, when an NT is elevated, it can be aneuploidy in about 60 to 70% cases, which could include commonly trisomy 21 or Turner syndrome. But non-aneuploidy structural defects may become evident later in 10 to 15% cases. We must be very much aware and counsel regarding the possibility of single gene syndromes like Noonan, skeletal dysplasia, Smith-Limley-Opitz, storage disorders, which are common in which may be noted in 5 to 10% cases. Lay emphasis, especially if it's a consanguineous couple, we could be dealing with a single gene syndrome, and other perinatal or maternal complications could occur in about 5 to 10% cases. Obviously, NIPT is not a test of choice. Now, in this case, we did a microarray. Karyotype was normal, but there was worsening on the scan wherein the fetus did show abnormalities, and ultimately they chose to discontinue. But in that case, we did an autopsy, and further on the DNA found out that this was a case of MPS 1 or Hurler's syndrome. So we have to be aware that increased risk on double marker is not equal to Down syndrome, and sometimes we may have to go to the gene level to give the couple a correct diagnosis. Now, in this case, what we are finding is that the pathway, there's a risk is in the intermediate category of 1 in 423. So we said that 1 in 250 to 1 in 1000 is considered to be an intermediate risk. And that's essentially because of a low PAPE. Obviously, we are going to start her on aspirin because of the low PAPE and the risk of a preeclampsia. But in these cases, essentially, further testing was considered. Now, the couple was very, very anxious. NIPT had shown a low risk, but the couple was extremely anxious and they considered a microarray, and that showed a 17q microdeletion. So sometimes I lay emphasis that if the marker trend is too adverse, especially the PAPE value being very low, should be considered for an invasive testing. So here it turned out to be a 17q microdeletion where it did not show any major physical abnormalities on autopsy. Obviously, you can see the postnatal outcomes that could be associated with this condition, like a 100% risk of developmental delay, a very high risk of hypotonia and seizures, and structural brain abnormalities. Okay, so essentially, these are the cases. Now, when you are evaluating these cases nowadays, because of the expansion of the prenatal screening, you can also look at the analyte PLGF along with the mean arterial pressure and uterine artery PI. You can give risks for preeclampsia using newer markers. Even that is possible in the first trimester. But again, coming back to now, this is a 38-year-old lady who is a precious pregnancy after a history of infertility. Double marker NT scan is absolutely normal, and a double marker showed an intermediate risk of 1 in 660. Now, essentially, that could be related to her age factor and a bit of beta HCG, which is elevated. So beta HCG is almost 3 times the normal value. So here we obviously need to look at whether the lady has been given beta HCG injections and so on. But these may be cases with appropriate counseling to be considered for a non-invasive prenatal screening or an NIPT. So essentially, if you're looking at it, if the risk is less than 1 in 1000, you can always counsel them that they need not consider any further testing and just consider a screening protocol. If the risk is more than 1 in 100 with more adverse markers, obviously an invasive testing with your FISH or a QFPCR along with a karyotype or microarray may be considered. The risks between 1 in 100 and 1 in 1000 should be tailored to be considered either for an integrated quadruple screening or go for an NIPT. Nowadays, NIPT, being better, a robust test where it gives almost a 98-99% screening accuracy for Down syndrome may be considered in these cases. But if that affordability is an issue, obviously you can integrate your double marker results with a quadruple if it is done with a quadruple design. You give an integrated result to the patient if it is done from the same laboratory. So what does NIPT actually do? It is looking at the fetal fraction which of the cell-free DNA, which is circulating in the maternal blood. So what we must remember that in the maternal blood there is a maternal cell-free DNA and a fetal cell-free DNA. So essentially about 20% of roughly 20% of the DNA could be a cell-free DNA, but that is the fetal fraction that we need to find out. So sometimes it can be as low as 3 to 4%. So the cutoff here is 3.45 to 4%. So always when you're reading an NIPT result, always look at the fetal fraction, because we need to get a robust result, we need a higher fetal fraction. Now, the risks again are a screen positive high risk or a screen negative low risk. Now, in this case, again, the risk is more than 1 in 20, and this is a high risk case. And obviously, you can see the cell-free DNA percentage is 9.09. So obviously, it's a good cell-free DNA percentage. But again, you have to confirm these by an invasive testing as of today, because though we do say that for Down syndrome, I would say the accuracy is fairly good, but still it should be confirmed by an invasive testing. And here it indeed showed a trisomy 21. Now, in this particular case, remember, it was a high risk for trisomy 13. So here in trisomy 13, we must remember the cells which are released from into the maternal stream or DNA is a placental DNA. So what we know, placenta is always a mosaic organ. So if it is a mosaic organ, there's a possibility that the fetus may not reflect the actual the cell-free DNA. So here we find it that though the risk for trisomy 13 is high, when you're doing a karyotype, there was no other marker, soft marker or anomaly on the ultrasound, and the karyotype was normal, the pregnancy was continued, and the outcome is normal. So remember that never to discontinue pregnancies based on the NIPT result. Always consider an invasive testing. But sometimes, unfortunately, you will land up with unexpected outcomes. There could be anomalies, intrauterine or neonatal deaths. So how do we approach these cases? We have to be ready for everything. So suppose we land up with this case, like for example, the couple is consanguinity, and there was hydrops, there was retrognathia, there was choroid plexusis, there was poor ossification of spine, so on and so forth, along with a lot of bony abnormalities, short curved long bones, flexion deformities. Obviously, the fetus was sent for an autopsy, and on autopsy, you must always remember a physical examination along with a radiological evaluation and a proper DNA storage helped us in reaching a conclusion that this was a TRPV1 gene related achondrogenesis type 1A. Now, one very important aspect here is this is a recurrent condition. It's an autosomal recessive condition, and obviously the risk of recurrence is going to be high for this family. Now, here in this particular case, we really know what is the importance of a fetal autopsy being done properly. So, the 14-week pregnancy with oligoamnios with lower centiles growth parameters, hydronephrotic kidneys, and over-distended keyhole bladder, CTEV, and the pregnancy was discontinued for this reason. Okay. Now, when I did the autopsy, because since I do an autopsy myself and being a geneticist, I am aware of all the dysmorphic features, etc. We do autopsies more meticulously to looking at various dysmorphic features. Now, the fetus had come to me for autopsy, and we could find very many different features. And you can see there's a cryptophthalmos over here, along with, see the malformed pinna, and you can see significant facial dysmorphism here. And very subtle, you can see a partial syndactyly and brachydactyly in the fingers as well. Now, ultimately, we had the genetic results at hand. The patient had stored the DNA and went for an exome sequencing, and it showed a compound heterozygous variant pertaining in the FRAS1 gene pertaining to Fraser syndrome type 1. Now, obviously, if we did not have these features at hand, the features on autopsy, it was very difficult for us to conclude whether it was a Fraser syndrome or not, because essentially the hydronephrotic kidneys and the distended bladder was possibly because of the PU valve. So it was possibly a dual pathology which was acting over here, and the main phenotype here was a Fraser syndrome. Obviously, it would have been evident a little later on scans, but if you just do an exome sequencing without a fetal autopsy, sometimes it will not give us a clear phenotype. Again, here in this particular case, this is a second conception of this lady, wherein in the previous pregnancy also she had a pregnancy which was discontinued. There was labor at 7 months and the baby died. Again, this pregnancy, she came at 24 weeks with very, very poor outcomes. There was pleural effusion, there was fixed movements, extended lower extremities, etc. So we explained poor prognosis to them, and the baby was delivered but passed away immediately. But what is very crucial here, we could take some photographs of the baby and we stored the DNA sample. The patient was not affording, they came later and they did a DNA testing and which showed a Musk gene homozygous mutation which pertains to a Pina-Schuker phenotype type 1. So proper counseling was offered, and in the next pregnancy, we could offer them a proper and early prenatal diagnosis. So how do you collect and preserve samples, fetal samples? Now, essentially, if you want to collect it for genetic studies and or DNA storage, you can always collect a small cord piece. Take about 5-6 centimeters of cord piece. Use a sterile container, a sterile urine culture bottle would do. Take some sterile saline, put some drops of gentamicin and store that cord. In case you can get blood from the cord or the cardiocentesis, you can collect it in EDTA. Some patients do prefer to do a CVS or an amniocentesis before discontinuation. If you want to store the placenta, it should be in saline gentamicin, and actual fetus you should store in water with 10% formalin. And always, if you want to do a brain biopsy, you should be injecting 20% formalin through the anterior posterior frontal and in any other sutures which would be open, because that would help in preservation of the brain. So always, when you're collecting the sample, collect it meticulously, because it's a very, very crucial sample for testing, wherein you're using saline gentamicin mixture or you're taking either a cord piece, placental villi, grade 2 tissue, etc. So sample collection is very, very crucial. Now, sometimes what happens is that there are events which happen much later. Now, this particular pregnancy, so there are two conceptions. The first baby was delivered by cesarean section, 2.5 kilo birth weight, did not cry at birth, died on day of life 1. It was suspected to be an HI. Again, the second pregnancy delivered by cesarean section, a good birth weight baby, had seizures, lethargy, and in this particular case, we could just manage to do an MRI in the baby, and it did show an HI-like changes. Now, here always the blame would go on the obstetrician that there was a delay, in delivering the child, and that caused the HI. But do we expect that two well-grown babies born by cesarean having an hypoxic insult? It's very unlikely. So in this case, what we found, we could store some blood sample and DNA, and we found that there was an MTHFR gene mutation, which was homozygous, and that caused antenatal thrombosis of the brain vessels, causing an HI-like picture. So we must be aware that these IUDs which are happening, especially any IUD between 20-24 weeks to about a neonatal death till about 1 month, at least about 30 to 40% of these cases could have a single gene etiology. So always store the DNA, try to investigate appropriately involving the geneticists so that we can come to a more logical conclusion in this regard and avoid major medico-legal issues. Now we'll go to the last part of it, wherein what kind of diagnostic testing should be carried out, because we're doing invasive testing, but we really don't know what we want to test for. So the common this thing would be, I divide it into two parts. When we're doing a rapid aneuploidy testing, a RAT, that is fish QF-PCR, a karyotype or microarray, we are doing a cytogenetic testing, chromosome level testing. Now this can be done for any of the families, essentially for any indication, this is all right. But when you're doing a molecular testing, that is PCR, Sanger, exome genomes, or MLPA, it should be really targeted. We need to know which part or which point we need to look at. For example, rapid aneuploidy testing by FISH or a QF-PCR, it screens only for the common chromosomes, 21, 13, 18, XY. It gives a very quick result. But it should be, when it is utilized, it's usually an adjunct to chromosomal testing. In resource-limited settings, when the patient is not affording, but the risk for Down syndrome is high, you could use it rarely as a standalone test. The second would be a karyotype. Karyotype is less expensive, but it's a test of choice to rule out mosaicism. Okay, it requires culture, a longer time for result, and it's very, very subjective. One person may find that there is a deletion, the other person may say it's normal. So a lot of subjective assessments here. You may miss microaberration because we are looking at the book from outside. We're not going to the chapter level. So it misses microaberration and small risk of culture failure. So here a microarray scores over a karyotype. So very in resource available settings, Especially, I would focus that if there are anomalies on scan, a raised NT, hypoplastic nasal bone, or any other major anomalies, and in resource available settings, you can always opt for a microarray. It is less subjective. It will give about 15-20% more information than a karyotype, but it may be cost prohibitive in certain cases, wherein you can always go for a basic karyotype. Always which resolution to apply is the question. When you're doing a screening, like for example, I'm doing a testing, primary testing for DMD, and I just want to screen the fetal chromosomes, I can use a low resolution. But if I'm testing for if there are major anomalies or soft markers, better to consider a higher resolution. Like in this particular case, it's a 37-year-old lady, the increased risk on double marker with mild ventriculomegaly. So mind you, ventriculomegaly is a soft marker here in this case because of a mild ventriculomegaly. Obviously, we opted for a microarray and it showed a 2p21 microdeletion, which had the 6.3 gene, which causes holoprosencephaly. So remember that this particular variation would have been missed on a karyotype and it was picked up on a microarray. Right. So similarly, anomalies like in this particular case, wherein there was a small nasal bone, the NT was normal, the nasal bone was suspected to be small and still remained hypoplastic at 16 weeks. Remember, it's only an isolated nasal bone hypoplasia. They opted for a microarray and it showed a pathogenic duplication of 6.4 MB on chromosome 9p, and that is something which causes a 9p23 duplication syndrome, and it could have led, otherwise physically the fetus was fine, but it could lead to an intellectual impairment, autism, and global delay in the baby. Again, this particular case, wherein 2 consecutive babies with a major cardiac abnormality. In the second case, when the testing was carried out, it showed a 22q microdeletion. So obviously, karyotype, when you're doing a microarray, you're going deeper to find out, and especially in cases of anomalies, it is the test of choice. Now we'll go to nearly the fag end of the talk, wherein we'll discuss about some molecular tests. That is when do you utilize exomes and genomes. So ideally, molecular tests should be guided by a geneticist or a trained genetic counselor to avoid complications, because nowadays we see a lot of complications arising because of the wrong test being done or the wrong variant being tested in the fetus. So proper pre and post test genetic counseling is essential, because we as geneticists would be able to explain what are the limitations of the testing that is being carried out. So various tests are available, like PCR-based tests, Fragile X, or an MLPA-based test, which are commonly used for 2 common conditions, DMD and SMA. NGS and exome sequencing will be utilized for carrier screening in couples or testing of index cases. And Sanger sequencing is limited to smaller genes or only to confirm the variants in the parents or fetus. Now, remember that prenatal diagnosis cannot be offered directly on the fetal sample. So always we need to have a correct and definite diagnosis in the index case. You have to test the parents and only then offer a prenatal testing. You can't send the patient directly at 16 weeks for an amniocentesis for a condition that you don't know. It's as if I give an example that you have 25,000 pages in front of you and ask you to search for something which you don't know. It is not possible to search for that. So ideally, the patient should be referred for a genetic evaluation preconception. But if not possible, at least at conception, they should be visiting, or at around 6 to 7 weeks. So still we have time on hand to really, because genetic testing would take any time between 4 to 8 weeks, 4 to 6 to 8 weeks, for testing. So still we would have time to offer a CVS or an amniocentesis. And nowadays, because of the extended deadline of 24 weeks, we do have time on hand. So an early referral to a geneticist is essential when we want to evaluate for these conditions. So we must differentiate between what is a procedure and what is a test. Venipuncture is a procedure, while tests to be performed on the blood are hemogram, thyroid function, sugar. So similarly, amniocentesis, CVS is a procedure. The tests to be carried out need to be decided on the family history, on the previous affected child's investigations, etc. So karyotype, FISH, microarray is the test which we need to choose depending on what the condition is there at hand. Like, for example, this particular family came to me. Now, this lady was already 12 weeks pregnant. There was a high NT of about 11.5 weeks and the low risk on double marker. So obviously, they came for a counseling. As geneticists, we would always expand the family history and we would ask for various questions going deeper and deeper. Now, what we found that her brother was intellectually challenged, had spasticity, seizures, and died at 9 years of age. I could get hand on one of the photographs which was hung on their family the house wall. And that did show that there was significant dysmorphism in the child. So at that point itself, I suspected that this could be a genetic cause. And looking at the time frame that in hand, I decided to consider a trio evaluation. So wherein I considered both the partners and the fetus together. And what we found is that the mother was a carrier of this ATRX gene mutation, which causes X-linked mental retardation hypotonic facies syndrome, and fetus was affected with this particular condition. So if a proper evaluation was not done, or only the chromosomes would have been checked, the lady would have landed up with a child with intellectual impairment similar to her brother. So remember that raised NT is not always Down syndrome or chromosomal abnormality. We have to evaluate the family history properly to reach a quite a logical conclusion. Now, in some cases, what we have is we do not have the baby as such available. Like, for example, in this particular family, they lost 2 children. The second child was also lost, but we had some few spots from the previous TMS testing. Nowadays, it is possible to obtain DNA from the blood spots or from sometimes the dried cord sample, by which we could offer that this particular child could be investigated even post-mortem, and we could identify a PIX10 gene homozygous mutation, and which was heterozygous in the parents, and therefore the risk of recurrence in this case was about 25%. So we could offer a good prenatal testing for the family. Nowadays, because of the advancements and the reduction in costs of exomes, we do offer a carrier-based screening, but it's very, very essential to give a proper judgment as to which of the variants should actually be tested in the fetus, because it should not happen that you're testing the wrong variants and landing in trouble later. Like, for example, in this particular case, there were 3 variants which were identified in the couple. Both were both of them were carriers for these 3 variants. And when we evaluated it pertaining to the previous child's phenotype, the SEPCES1, which was the variant which was a pathogenic variant, while 2 other variants were the SLC6A3 and the DOC3 were variants of uncertain significance. On clinical evaluation, what I found that there was some blend between the first and the second genes. So ideally, it should be considered for only pathogenic and likely pathogenic variants, but with proper counseling, you can consider prenatal testing for VOUS, but with a proper genetic pre and post-test genetic counseling. Now, just my last case wherein I highlight what is the importance of proper genetic evaluation and counseling. The first child is my patient who is a known case of VLCAT deficiency, which is a metabolic disorder. Now, this child has been under my treatment for the last about 5-6 years, and she had presented in a really critical state of hypoglycemia, hepatomegaly, and cardiomyopathy. And the second pregnancy landed up with a sudden neonatal death on day of life 3, which I again suspect could have been because of the metabolic condition. She came with a third pregnancy, and we had identified the mutation in the index child, and this current fetus was also found to be affected with the ACA-DVL gene mutation. Now, in this case, what we did is I discussed with her that again, there's a recurrence of the condition. So whether she would want to continue or discontinue the pregnancy. She was well under 24 weeks at that time. But the mother wanted desperately to continue the pregnancy. So I discussed with them that we have an option to consider an antenatal treatment. So that I started her on carnitine and also an MCT-based diet right from 22 weeks only. And ultimately, the fetus was born. Though biochemical signatures of the disorder were present, but the child is absolutely normal now, almost 3 years of age at this point in time, absolutely asymptomatic till date, because the lady was given this particular MCT and the carnitine, which transplacentally reached the baby, and ultimately, once the baby was born, did not have an immediate event of neonatal death, because VLCAT deficiency is known to cause neonatal deaths. So essentially, that can be averted if you give proper counseling, and not all conceptions, having an affected, babies should be considered for discontinuation. So proper counseling is very essential in all these cases. So my take-home messages would be, in low-risk cases, always consider periconceptual vitamins, very, very crucial to prevent neural tube defects, thalassemia screening for all, proper scans for everyone, and Down syndrome screening for everyone. It just should be the standardized NT and biochemistry. NIPT can be an option, but the cases should be correctly selected. You can give an option to all of them nowadays, because the American College of Medical Genetics also has approved NIPS as a good screening test over the NT, but we must choose the cases correctly. There should be no soft markers or anomalies, and the marker trend, if a biochemistry has been done, should be normal. and then NIPT definitely can be given an option. But if there's an abnormal scan or marker pattern, it should prompt more extensive testing, that is an invasive testing. Remember, for products of conception, microarray should be preferred, but when you're testing couples, it should be a karyotype as a baseline. All families should be with bad obstetric history should be given a correct and definitive genetic diagnosis early, and a timely referral to a genetic testing facility is very, very crucial, wherein you can really identify the cause and give a proper prenatal testing. And no family should ideally be left without an attempt to a diagnosis in this era of genomics. So it's like a teamwork which has to happen, wherein the obstetrician, along with the fetal medicine expert, the geneticist, the laboratory, all have to work together really to give an optimal outcome and a happy outcome to the couples. So with that, I would end my talk and would be happy to take questions whenever the chairpersons suggest. Thank you.
Thank you so much, Dr. Chaitanya. I think it was a wonderful deliberation. You have so detailed explained, the case wise, in which case we should go for microarray, which cases are going for specific karyotyping. That was really nice, and I think the bottom line is diagnosis. You have to make a diagnosis to give an optimal outcome for both the mother and the fetus. I think, thank you so much for such an enlightening lecture today.
Thank you.
Thank you.
Thank you so much.
Thank you, Chaitanya sir, and thank you, Indrani ma'am, for your inputs. Now, let's move to the second lecture. To chair the second session, I'd like to invite Dr. Jitendra Nath Gogoi. Sir is consultant obstetrician gynecologist at Jeevan Jyoti Clinic, Satyam Nursing Home. Sir is past president of Jorhat Obstetrics and Gynec Society. Welcome, sir. I'll request Jitendra sir to kindly introduce our speaker, Dr. Manoj Toshniwal sir. Dr. Jitendra.
You're muted.
Jitendra sir. Jitendra sir, please introduce.
संहितेला सांग ना. संहितेला सांग त्यांना अनम्यूट करायला. संहिते.
Sir, kindly unmute, sir.
Yeah.
Can you unmute from your side, Saidesh?
Yes, ma'am, I have given the request, but sir has not accepted.
Yeah.
Yes.
Yes.
Jitendra sir, please introduce our next speaker.
Yes. Good evening, everybody.
Again unmute.
Yes, again got muted, sir. I think you're. Yes, now okay.
Now, okay?
Yes.
Yes, sir.
Yes, okay. Our next speaker is Dr. Manoj Toshniwal.
No, again got muted, sir. You're pressing some button which is muting.
Hello?
Yes, sir,
now
you're
we can
audible,
hear you.
please.
Yeah. Yes, audible. He is the consultant hematologist and a hemato-oncologist and bone marrow transplant physician. He is DM on clinical hematology of CES GSMC and KEM Hospital, MUHS, Maharashtra, India. He is a gold medalist. He is the fellow in bone marrow transplant and Tata Memorial Hospital, Mumbai. He did the fellowship in leukemia and bone marrow transplant in British Columbia Cancer Agency, Vancouver, Canada. He is MD in internal medicine, Government Medical College, Aurangabad, MUHS, Maharashtra, India. He is MBBS from Government Medical College, Aurangabad, MUHS, Maharashtra, India. He is the only hematologist in the country to have 2 fellowships in bone marrow transplant. So he's a very genius young physician in this field. I request Dr. Manoj to deliver his lecture on hemoglobinopathies. because hemoglobinopathies, as we know, it is one of the rather a common common genital defect, particularly in the hemoglobin, particularly in the globin section of the hemoglobin part. So it has both we all know both qualitative and quantitative defects. When the quantitative defects, there is a thalassemia, and qualitative defects, we have got different traits. Particularly in northeast region, in our areas, the E trait is very common. This all hemoglobinopathies causes anemia, and we come across many cases of such hemoglobinopathies. So I request Dr. Manoj to enlighten us with this important method. Dr. Manoj, please.
So thank you, Jitendra sir, for your kind introduction. And thank you, Dr. Sujit sir, OBGY Society, Dr. Rajendra sir, madam, everyone for inviting me. I'll just share my screen for my presentation. Where? Is it visible, my presentation?
Not yet, sir.
Is it okay, no?
So please click on share screen option, sir, which is in green color.
Yes.
Yes, if you click on that, please select the PPT window and then share.
Is it okay now?
Yes,
Yes, sir.
Yes.
Yeah. Now it is visible.
So is it moving? So first of all, I thank all of you at the outset for inviting me for this webinar. Dr. Chaitanya sir's talk was really fantastic. When I, being hematologist, not involved in gynecological practice at all, but still I was continuously listening to your presentation. It was such a nice presentation. I must congratulate sir for such a lucid presentation, such an excellent talk on genetics in gynecology. So you all are experts. I'm not someone who is expert of to talk in front of you, but I know a little bit more about hemoglobinopathies, and we want to discuss something good today. That is why I'm standing on this side of desk, where I will discuss about hemoglobinopathies in pregnancy. So in between also, if you have any question, please feel free to drop that in question and answer box, or even at the end of discussion, we will discuss about hemoglobinopathies related questions, or even something which is hematological and pregnancy, which I am able to answer as a question. So let's start with hemoglobinopathies. So what are hemoglobinopathies? These are inherited disorders of hemoglobin. It is quite a vast chapter when it comes to even hematologist. When it comes to gynecology, I'll just stick to the sickle cell disorder, which is usually a most common hemoglobinopathy across the globe, the various thalassemia syndromes, and some others, and pregnancy-related problems which we routinely see. Why we are talking about thalassemia today? Because we still have most cases of thalassemia all across the globe. Yes, sickle cell is common in all other parts of the world, but when it comes to thalassemia, particularly thalassemia major, still in our country we have more than 1.5 million patients who are having thalassemia major. They need bone marrow transplant, but government is not supporting them. We know that it is preventable disease, but still every year we are producing more than 10 to 15,000 patients who are having thalassemia major. Overall cost of taking care of them is also very high when it comes to the blood transfusion, tablets and everything. It is a preventable disease, and that is why it needs to be talked for sure. And that is why we are here to talk on thalassemia and pregnancy. Thalassemia minor, we all see commonly in our clinical practice, but just we don't know what to do with it, and that is why we miss on it. This was just Aadi Wali Zindagi was something as a campaign was run in the Bollywood few years back. Aadi Wali Zindagi Mitao, when they were propagating information about thalassemia minor. So thalassemia beta minor or beta trait is when there is reduction in production of one normal beta globin chain, and this can be encountered in pregnancy more commonly. When it comes to the hemoglobinopathy per se, I think thalassemia minor is the most common condition which all the gynecologists come across. When we do routine CBC, patient have low MCV, MCFC. The MCH value is also low. We do HB electrophoresis, and in that we find HbA2 is on higher side, maybe around 3.5%, between 3 to 4, and HbF is also increased. So in patients who are microcytic hypochromic anemia, where MCH is reduced, yes, we should suspect patient might be having thalassemia minor. In those cases, it can be confirmed with the HB electrophoresis. If HB electrophoresis shows HbA2 between 3 to 4, usually around 3.5, it is confirmatory that it is thalassemia minor. Thalassemia minor, usually diagnosis is made only when microcytic hypochromic anemia fails to respond to iron. And in those cases, usually the maternal and fetal outcome is good. But if we miss the diagnosis, and if the husband is also thalassemia minor, sometimes we may land up with thalassemia major kid, and that is why we should know when microcytic hypochromic anemia, if it is not responding to iron, or if MCH level is also less, better to get HB electrophoresis done. Ideally, for every young individual, HB electrophoresis should be done. This is one more question which keep on popping. Parental iron. Few of us think that parental iron is contraindicated in thalassemia. It is contraindicated in thalassemia, but in thalassemia major, not in minor. Minor is such a condition where they have low hemoglobin because of thalassemia minor status, but that doesn't mean that they will not have iron deficiency anemia. Considering iron deficiency anemia being so common in our country, many a times we will end up with patients who have thalassemia minor along with iron deficiency anemia. So doing a proper iron deficiency status evaluation, and if patient is iron deficient, yes, they need IV iron for sure. Even after IV iron, their hemoglobin will remain around 9, 10, 11. And in those cases, they may sometimes need blood transfusion before delivery. There is no specific level where we should transfuse them or we should keep as a hemoglobin. It all depends upon the particular individual. If patient is asymptomatic, yes, we can go ahead with around 8 hemoglobin also for the normal delivery or LSCS. But many a times we land up in giving blood transfusion just because gynecologist is scared or patient is scared. My hemoglobin is low, I should not land up in trouble with LSCS or normal delivery. So yes, folic acid is routinely given. Iron is not indicated unless deficiency is documented by serum ferritin and iron studies, and blood transfusion when hemoglobin is less than 8 or patient is symptomatic for patients who are having thalassemia minor. Sickle cell disease, yes, as we have already told, it is the most common inherited condition worldwide. Usually it is homozygous sickle cell anemia or SS disease. Sometimes they are compound heterozygous for SC, or sometimes they are sickle beta thalassemia. It is because of substitution of glutamic acid to valine at the 6th position in the beta globin chain. Thalassemia we commonly see in Indian subcontinent. We don't see it in Western world, but sickle cell is all across the globe for sure. But unfortunately, India is somewhere having a huge incidence of sickle cell disease, and that is why we commonly see patient of sickle cell anemia coming to our OPD with pregnancy. Why it is important to know? Because under the condition of hypoxia, cold, acidosis, dehydration, usually these red cells become sickled in shape, they get hemolyzed early, and patient gets anemia and jaundice. They are rigid and fail to pass through the microcirculation, causing intravascular thrombosis, leading to the sickle cell crisis, which is severe painful vaso-occlusive crisis and leading to the tissue infarction. It can occur in any organ, leading to renal damage, splenomegaly, hepatomegaly, pulmonary infarction, even cerebrovascular accident or leg ulcer. Common thing which comes into picture when it comes to gynecological or obstetric practice is acute chest syndrome. Patient develops severe pleuritic chest pain, fever, cough, and hypoxia. Usual pathology is underlying infection, infarction, fat embolization can also be there. Recurrent episode make them prone to develop pulmonary hypertension, and both these things, the vaso-occlusive crisis and acute chest syndrome, are common in pregnancy. So whenever a patient of sickle cell disease is there who is pregnant, yes, one must keep in mind that she can come with acute chest syndrome or vaso-occlusive crisis. Pregnant women can also have cardiac dysfunction due to ventricular hypertrophy already. And when patient with sickle cell is there, they have chronic pulmonary hypertension. There are changes in the placenta because of feto-maternal circulation being affected that can lead to early preeclampsia or harmful effect to the fetus. And many of these patients have chronic hemolytic anemia going on, and generally they look healthy except during crisis, and they land up in crisis early. And that is why they need to be in regular follow-up with hematologist and gynecologist during their pregnancy. Screening for high-risk population can be done by HB electrophoresis, and if HB electrophoresis shows good HbF value, many times it is first time diagnosed in pregnancy because they remain asymptomatic but they become sick during pregnancy. So HbF, somehow it is protective, and that is how the hydroxyurea works. These are the complications which we expect during pregnancy to patients who are having sickle cell disease. Acute painful crisis, as I have already told, the chest syndrome, early onset preeclampsia and HELP syndrome, that is hemolysis, elevated liver enzymes, low platelet syndrome. Various infections because already they are immunocompromised due to the condition. Pyelonephritis, puerperal sepsis are common. Thrombotic risk and cardiac dysfunctions are also common in patients who are having sickle cell. Perinatal complications like miscarriage, intrauterine growth retardation, intrauterine fetal death, and isoimmunization and hemolytic disease of newborn because of the ongoing hemolysis and previous transfusions is also common in patients who are having sickle cell. For these patients, one must plan pregnancy properly. Pregnancy should be planned and chronic disease evaluation should be done preconceptually for end organ damage like hypertension, proteinuria, the retinopathy, nephropathy. This needs to be evaluated already. Echocardiography should be done previously so that pulmonary hypertension, cardiac dysfunction can be documented. If they have multiple blood transfusion, they should be screened for iron overload, and SOS chelation should be planned, particularly in patients who are compound heterozygous or sickle beta thal. Usually for sickle cell, they don't need more transfusions, but patients who have compound heterozygous or sickle beta thal, they need repeated transfusion and get iron overload and liver dysfunction. Also, red cell antibodies are also indicated if they have received already multiple transfusion, so that we can plan for hemolytic disease of newborn related management periphery. Hepatitis B vaccination should be given. Other vaccinations are also needs to be given because they have autosplenectomy and they are prone to develop infections during the immunocompromised states. So influenza, swine flu, or even various meningococcal and pneumococcal vaccine needs to be given. Folic acid supplementation should be continued throughout the pregnancy as 5 mg daily. And hydroxyurea, which is the important drug in the management of sickle cell disorder, which we usually give throughout life for them, should be stopped at least 3 months preconceptually. That is how the literature mentions. Hydroxyurea increases the HbF value. It prevents the sickle cell crisis, but it is supposed to be a cytoreductive agent. It is not safe in pregnancy, And that is why we advise them, if you are planning for pregnancy, better to stop 3 months before, or once you detect the pregnancy, immediately it needs to be stopped. At least for first 1 or 2 trimester. Last trimester, we may continue if patient is landing up in recurrent sickle cell crisis. The antepartum management contains women should aim to avoid precipitating factors so that sickle cell crisis never happens throughout the pregnancy. Influenza vaccine should be administered. Partner screening should be done, and prenatal diagnosis should be offered. Folic acid to be continued. Iron status, according to iron status, we should plan for the iron. Low dose aspirin, that is 75 milligram daily, from 2 weeks of gestation in an effort to reduce the risk of developing preeclampsia and IUGR is indicated, and there is valid uh, clinical support to this step, that they should be on low dose aspirin throughout pregnancy, and it reduces the preeclampsia and IUGR incidence in patients who have hemoglobinopathy. Blood pressure and urine analysis should be performed at each consultation, because they are at high risk of developing asymptomatic bacteriuria, and it may turn into a pyelonephritis, and they may land up in sickle cell crisis. Blood pressure should also be monitored, which can be an early indication for preeclampsia. Apart from routine anomaly scan, they should be offered monthly growth scan to look for feto-maternal circulation, if it is properly or not. If it is not, then prophylactic blood transfusion or what you call exchange transfusion needs to be planned for them. Routine prophylactic blood transfusion is not recommended, but if scan shows patient is having feto-maternal if that feto-maternal circulation is not proper, it can be corrected with blood transfusion by keeping hemoglobin on higher side, or by doing exchange transfusion, in which we remove almost 300 to 600 ml of blood from patient, and then we give 1 more unit of fresh blood transfusion to the patient. That reduces the sickle cell percentage to below 50% to make them sickle cell trait, and it reduces the feto-maternal compromise. We intrapartumly, this can be the thing which can happen, like acute stroke, severe anemia, even thromboprophylaxis is needed. Severe anemia can get worsened because of the painful crisis, and that is why elective delivery is preferred after the 38 weeks of gestation to this patient. If IUGR is present, rather than waiting for things to turn bad, better to get them deliver early, because we have burnt our finger many times by making it let's wait, and by the time the patient lands up in crisis, they give very less time. It is compromised for fetus, it is compromised for patient as well. Vaginal delivery is preferred, but if patient is in sickle cell crisis, we should choose as early as possible, take the decision about LSCS. And in that also, general anesthesia better to be avoided, because it precipitates many of the anesthetic agents, precipitate the sickle cell crisis, and that is why epidural anesthesia is preferred. Blood should be ready, and in case of atypical antibodies, it should be cross-matched for delivery. Adequate hydration and oxygenation should be maintained intrapartumly. And postpartumly also, they need that aspirin throughout pregnancy we continue, but it is indicated that preferably heparin should be given prophylactically to prevent the thrombosis. Infection should be watched and vigorously treated in puerperial period. Baby should also be tested for sickle cell disease. Contraception is very important. Combined OC pills needs to be avoided, and progesterone only pill are more useful, because progesterone is known to prevent the sickle cell crisis. IUCD contraceptive devices are risky for infection, and that is why progesterone only pill is something which is preferable in patients who are having sickle cell disease. So this is all about sickle cell. So sickle cell is common condition. Usually they keep on coming with pregnancy to you, and this is how we manage antepartum, peripartum, and post antepartum throughout the pregnancy and delivery and postpartum. Thalassemia, yes, thalassemia, alpha, beta, major, minor. We all know a little bit about it, but there is huge confusion when it comes to the alpha thalassemia. So when alpha chain production is affected, we call it alpha thalassemia. When beta chain production is affected, we call it beta thalassemia. Alpha thalassemia is from chromosome number 16, or when 1 or 2 is missing, it results in alpha thalassemia trait. They are usually silent carrier. If 2 genes are missing, they are thalassemia minor, and the pregnancy is well tolerated. They remain asymptomatic. They should be given oral iron, folate, and all and routine pregnancy management should be continued. If 3 genes are affected, we call it as HbH disease. Usually these women come with hemolytic anemia and it deteriorates during the pregnancy. For alpha thalassemia, parenteral iron is contraindicated. Oral iron should be given only if ferritin is low, and if all 4 genes are affected, we call it as alpha thalassemia but which is not compatible with the life. Prenatal diagnosis of alpha thalassemia is little difficult, but usually through initial HB electrophoresis followed by genetic testing, we diagnose them with alpha thalassemia trait or HbH disease, and in that we have to go by chorionic venous sampling for DNA analysis if partner screening is positive. Thalassemia major is also called as Cooley's anemia. Usually these patients don't come to your clinic with pregnancy, but now with better management of these patients, they are living longer, and yes, they are coming with pregnancy to you. I'm very glad to say that in last 2 years, we have delivered 3 thalassemia major girls who have normal baby. So they got up to the age of 18, they were good. Their endocrine function were good because of the proper care. They got married, planned pregnancy, IV chelation was planned, and now they delivered the baby. So thalassemia major, though it is rare to come with pregnancy, thalassemia intermedia is something which usually comes. Thalassemia intermedia is something in which patient doesn't need regular blood transfusion. They have splenomegaly, they come with pregnancy to you, and this needs to be understood rightly to have the peripartum management. Usually in these patients who are thalassemia major or thalassemia intermediate, they keep on taking blood transfusion regularly. They need iron chelation. So iron chelation needs to be proper if they are planning the pregnancy. So chelation with high dose is given to woman who is planning pregnancy. Assessment of iron overload, cardiac status, liver function, thyroid, parathyroid, or even diabetes needs to be checked because of years of transfusion leads them to the what you call iron overload in the body. Cesarean section is something which is more likely to be planned for them because their bones are small because of chronic iron overload. Pelvis size is not normal, and normal delivery is usually not possible in them. Prenatal diagnosis wise, if 2 thalassemia major patient marry, all of these children will have disease. But if one partner is having thalassemia major, other has trait, chances are 50%. And if other is normal, all will have trait. So both the parents, so this is how usually it works by the Mendelian rules. So to understand, so far so good. Thalassemia minor is something which usually will come to you. For thalassemia minor, we need to diagnose them rightly. If iron deficiency anemia is there, which is not getting corrected with iron, MCV is very low, RBC count is good, MCH is also low, better to get HB electrophoresis done, look for HbA2 level. If thalassemia minor, still she can be iron deficient, look for iron deficiency status and treat that iron deficiency anemia properly. Sickle cell trait, same thing is there. You just need to diagnose them. Nothing needs to be done for them. They are normal individuals. If sickle cell disease is there, peripartum management needs to be rightly planned. Pregnancy needs to be rightly planned. Throughout pregnancy, hydroxyurea and other things needs to be properly planned. Hydration, blood transfusion, regular monitoring, regular scanning needs to be planned. HB level needs to be kept rightly, and during delivery we need to give epidural, and a team of a comprehensive approach needs to be there for sickle cell disease patient who is going for the delivery. It has to be properly planned delivery, and early intervention is always helpful, because if we delay, it can be a big compromise to the baby, big compromise to the patient as well, because we wait for almost 38 weeks and just for a day or two and everything goes into the drain. So we need to be very vigilant on sickle cell disease with pregnancy. Thalassemia major, they also come with pregnancy nowadays, because nowadays life expectancy is good. For them, a proper planning of pregnancy should be there. Before pregnancy, iron chelation, and during pregnancy, proper monitoring of cardiac function and preeclampsia status, followed by the LSCS. So whenever there is will, there is a way. That is what we can say. Just to sum up my things, anemia, we all are discussing about hemoglobinopathies, which are very rare. But anemia in India is very bad seen. And whenever it comes to talking to the gynecologist and my colleagues, I usually end my talk with anemia, because we are the one we should be aware about anemia, because almost 50% of Indian women are still anemic, just because we are not paying attention to it. 51% of Indian women between this age group, the reproductive age group, being anemia. This was the article in Times of India 2017. I thought we all are working on it. In 5 years time it will change, but unfortunately the survey which was done after 5 years shows that it has gone up rather than coming down. So even after we all are working relentlessly for the patient, somewhere percentage increase was there, almost 10 to 15% increase in anemia prevalence as compared to the 15-16 to 19-20, just because we are not paying attention to the anemia rightly. Even our kids are anemic because our woman is anemic. So 56% of Indian children were found to be anemic in this National Family Health Survey. And I urge all of you to pay attention to this thing. And the most important part in this is just to read that CBC completely. If we read that CBC completely, a patient is having low hemoglobin, take that seriously and start treating rather than making it worse to the level of 6 or 7. If hemoglobin is less than 12, it's already anemia. These are stages of anemia. And anemia is like last stage. Usually it is normal hematopoiesis, then iron depletion, then iron deficient erythropoiesis, and then it is microcytic hypercopic anemia. So by the time patient is having hemoglobin of 10, it is already late. But we are still ignorant about that part, and that is why this is day by day increasing only. It can be absolute or it can be functional iron deficiency whenever patient is having various other conditions. So rather than just ignoring it, we should opt from these three. It is always better to go by oral means, because it is time tested. Since many years we are using it. Nowadays parenterals are also available in good quality and with assured result. With fast moving word, it is not possible for patients to take 6 months of therapy. We can guide them for better parenteral drug, so that 1 or 2 doses is get corrected as early as possible. Transfusion needs to be kept for the last thing only, because transfusion doesn't come without any risk. Recently only I have seen 2 patients who are pregnant in Parbhani who received transfusion and landed in ICU actually. So better to avoid transfusion for nutrition anemia. Start with oral. If you feel oral may not work rightly, we have the option of IV iron, which are very safe nowadays. These are how they have evolved. So rather than thinking that IV iron is not safe or I am not still comfortable, now we are in the 2023 where we have very good iron molecules, safe at high dose also. These are near ideal, ferric carboxymaltose and iron also maltoside. Both of them are like ideal because they have tested in various settings like oncology, cardiology, even inflammatory, chronic kidney disease, even pregnancy related things also. They have this pregnancy category. There are n number of studies which show that IV iron is safe in pregnancy as well. For all our patients, if patient you feel that he or she may not be responding to oral iron, may not be compliant to the oral iron, make sure that you advise them to go for at least 1 or 2 doses of IV iron. So this is all from me. So problem is real, needs your attention to make India anemia free. Let's start reading CBC completely. Let's start making sure that you take hemoglobin value of 12 as mandatory thing rather than 10 ही रहता है, 9 ही रहता है. We are okay with that. It should not be accepted. Go for evaluation whenever it is needed. Half evaluation always risky. Advise patient proper serum ferritin, fasting iron studies, and whenever possible HB electrophoresis also. IV iron options are safe, cost-effective measure. Advise rightly to the patient. These sickle cell patient, thalassemia patients, they need specialized patient care when it comes to the pregnancy. They are coming to you. If you pay attention, yes, it is easy to manage them and you will have a very bright outcome at the end of pregnancy for sure. Overall goal of all this thing is thalassemia free India, because across the globe thalassemia incidences come down significantly, but still in India we are producing 10 to 15,000 babies who are thalassemic. So every young individual should know the thalassemia status. Prenatal diagnosis should be offered to them. If it is positive, it needs to be aborted. If it is negative, it should be continued. So yes, if we all pay attention to it, we will all find the way. This is all from me. Thank you so much.
Yes. Thank you.
Yes, sir.
Yes. Thank you, Dr. Tasniwal, for your nice talk regarding this special parts of thalassemia as well as the other hemoglobinopathies, particularly the sickle cell anemia. Yet you have told that we always do thorough investigation, particularly CBC as well as the hemoglobin level. Also, when we need see that anemia, we must do electrophoresis. So we should have the proper diagnosis. He also highlighted that although we believe that in thalassemia iron is contraindicated, not so. Iron also can be taken in case of thalassemia. So if the serum creatine level is low, then we must give iron whatever the way. He has highlighted the value of IV iron and blood transfusion is the last resort, and that also has to be taken care. And I again thank you, Dr. Tasniwal, for this nice clinical talk, and I also thank Dr. Sujit for giving me the chance to come acquainted with you all, and Dr. Rajendra Singh, whom I know since long time, and I'm very much happy to see you, Mr. Rajendra. Namaste. And thank you very much. And now,
Thank you, Jitendra sir.
any question you can. For any question, you can invite question.
Thank you, Jitendra sir, for your expert comments. Thank you, Manoj sir, for your excellent lecture. Now, with this, we conclude our academic session. I'd like to extend our heartfelt thanks to Dr. Madhuri Patel, Dr. Sita Ramamurthy Pal, ma'am, Dr. Chinmay Radha ma'am, Dr. Rajendra Singh Pardeshi sir, Dr. Sujit Konkar sir, President and Secretary of Aurangabad Society, Dr. Aparna Rao and Shraddha Paritkar madam, Dr. Indrani Roy, Dr. Jitendra Singh Gogai. And lastly, we are very much thankful to our talented speakers, Dr. Chaitanya Datar sir and Manoj Toshniwal sir, for their excellent presentations. Thank you very much, Shield Healthcare and Sahiti Priya, for all the support. Thank you, everyone.
Thank you everyone for attending. Thank you so much.
Thank you. Thank you.
Bye.
Thank you, Gogoi sir. Thank you.
Thank you.
Thank you. Dr. Indrani, thank you.
Thank you, everyone.
Thank you, sir.
Thank you.
one question for Dr. Manoj. Instead of bone marrow transplantation, we have other options like other genetic options in case of leukemia and other diseases. Stem cell, do you have any role of stem cell therapy? Not in anemia, but in oncology, in cancer cases, particularly leukemia.